All right. So, I've split the cardiovascular system up. Today we're going to do the heart. Later on in the semester, we're going to do the circulatory system. And it's done that way for a reason, which will become apparent once we get to the circulatory system. So we'll just do the heart. Actually, it's so it fits anatomy. And I'm going to start. You guys already had anatomy of the heart, right? You guys, this is all you did yesterday. So I feel it's not out of the box to assume that you know what you're talking about. Did red work? You guys want a different color? Green? Let's do green. To go through the path of blood through the heart, because I know you guys have done this before, right? At some point, yeah? So, all right, assume these represent tissues. All right, and of course these represent lungs. So blood is coming back to the heart through the vena cava. Goes into here. What's this? Right atrium. To the right ventricle. Through the tricuspid. And then into the pulmonary trunk, through the pulmonary valve, into the left and right pulmonary arteries. Oxygen gets exchanged with carbon dioxide. You come back through the pulmonary veins, excuse me, and enter the left atrium. Dang it. Through the mitral valve or bicuspid, into the left ventricle, through the aortic valve and into the aorta. Okay, then all the way back out to the body. That's the normal path of blood through the adult heart. Okay, the reason why I did that first is we're going to start with fetal circulation. So in order to understand fetal circulation, you need to understand what goes on in adult circulation. All right, so we're not going to go into like all the details of the actual fetus. We're just concerned with the circulatory system. So this structure right here would be the placenta, where the fetus's blood comes in contact with the mom's blood. Not direct contact because it is a capillary system with these chorionic villi. But then they feed and then they go into the fetus's circulatory system through the umbilical vein. By definition, what is a vein? What direction does it go? Towards the heart. So you're going away from the mother, but toward the fetus heart, right? So that's why it is a vein going towards the fetus. So one umbilical vein. All right, as blood comes into the umbilical vein, all right, and where does it come in? Umbilicus, right? So from there, it partially bypasses the liver, all right? Why would we partially bypass the liver? Isn't it a living organ? Doesn't it need blood? Yeah, but why do we bypass it? Crickets. It's formed. Come on, it's 8 o'clock. You guys are active in anatomy. Come on.
You want it to go to the heart first?
No. Because it's going like it would normally pass through the liver. Is the liver doing anything at this point? No. The baby's not eating, right? The baby's not eating, so the liver doesn't really have to do a whole lot yet. So it needs just enough blood supply to keep it alive. So it partially bypasses. And that bypass is called the ductus venosus. All right, so that's the first bypass. There are 3 bypasses in fetal circulation. All right, so then you're entering into the inferior vena cava. And of course, we just noted that the inferior vena cava went into the right atrium. Okay? From the right atrium, most of the blood gets shunted directly to the left atrium. Right? Most of the blood gets shunted directly to the left atrium. So, if we're doing that, what are we bypassing? Pardon?
All the blood going to the right ventricle.
And therefore,
You're not getting enough blood.
the lungs.
Yeah.
The lungs. We're bypassing the lungs. All right? Why are we bypassing the lungs? We're not breathing. Okay? We're not breathing. So I'll also tell you that because we're not getting as much blood to the lungs and they're full of liquid, they are under high pressure, much higher than the left side. Okay? And the lungs, the circulatory system of the lungs is under high pressure. So that means that there's going to be a high back pressure into the right side of the heart, forcing fluid into the left side. Okay? Because it's harder to push the lungs, so it's got to take the easy route and go to the left side. All right, that's going to be important for when the baby's born, how things change. So keep that in mind. All right, that shunt right there is called the foramen ovale, and you guys saw that yesterday in the adult heart, which is it turns into the what? The fossa ovale. Right. It's fossa means indentation, so it's a little indentation where that foramen or hole used to be. Right. So we're here. Right. However, some blood still goes to the right atrium, goes into the pulmonary trunk, and we go to the next slide. Goes into the pulmonary trunk, and from the pulmonary trunk, it would go to the left and right pulmonary arteries.
Thank you.
Did you know bless you was a little prayer people did for the plague? Like that's a legitimate thing. So why people still say bless you when the plague is completely taken care of is beyond me. I don't say bless you anymore. All right, segue. So we go to the lungs, but we said we want to bypass the lungs. So there is another shunt right here that goes directly from the pulmonary trunk to the aorta. So again, it's what we call a right to left shunt. All right, we're shunting from the right side of the heart to the left side of the heart because we need to get blood to the rest of the body, and the oxygen's coming from mom, not the lungs. Okay, then of course it would go out to the body, go through capillaries, come back into the umbilical arteries. Bless you. Umbilical arteries, and then back to the chorionic villi to exchange all the waste that just got exchanged at the capillary level from the fetal circulation. All right, so we went into the body, the fetus body, we bypassed 3 points, and then we take it back out and exchange with mom. All right, closed system. One real quick thing. With the foramen ovale, it's a flap. It's literally a flap. Let me erase this. It's kind of a flap like this. Okay? So that high pressure is forcing fluid through that flap. Okay, I forgot to mention that. When the baby's born, what are the big changes right away? Lungs. Lungs are the big changes because you go from a low gravity fluid environment to a high gravity air environment. All right, so your lungs are now going to provide that oxygen, get rid of the carbon dioxide. So that's going to drive most of your changes in the fetal circulatory system. All right, this is just a flow diagram of everything we just talked about. It looks confusing, but if you follow it, it just shows where the shunts are and excuse me, the parts that are bypassed. Okay, liver and this. So that's the only extra things that are on there. All right, when the baby's born, umbilical cord's cut. Okay, umbilical cord's cut. These umbilical arteries, the umbilical vein and the umbilical arteries are no longer sending or have blood in them. All right, so they shrivel up and they become ligaments. All right, the umbilical arteries become the medial umbilical ligaments, which have no known function, and if you cut them, no big deal. The umbilical vein becomes the ligamentum teres. Now, if you go look up ligamentum teres on the internet, you'll come up with the ligament that holds the acetabulum of the femur into the head of the femur into the acetabulum of the hip. Okay? Different ligamentum teres. This is also known as the round ligament of the liver. Not to be confused with the round ligament of the uterus, which no genetic male has. That was supposed to be a joke. You guys are tough this morning. All right. So, those are changes there. When the baby takes his first breath, what happens to those lungs? They expand. What do you think happens to the pressure when they expand? We talked about this, right? When things increase volume, the pressure decreases. So what's going to happen to the pressure in that right side of the heart now? That's also going to decrease, all right? Below that of the left side now. So you're not going to have blood flowing through that foraminal valley. Now the left side's going to be higher pressure. What's the consequence of that? That little flap right here that we talked about gets held shut by that high pressure. It gets held shut, and it gets held shut so tightly that scar tissue forms around it and it closes. Okay? So it's literally a mechanical event that's forcing this thing closed. And so people that have a patent foraminal valley when they're older, you guys have heard of this probably before, that never closed for one reason or another. Like maybe the connective tissue didn't seal it quite properly. Okay? Sometimes it causes problems, other times it doesn't. I had a friend who, when he was diagnosed, he was like mid-50s, and they just found, and exercised all the time, like super bicyclist, just found out he had a patent foraminal valley.
Is that when they do like the PFO closures or whatever? The patent foraminal valley?
Yeah. Yep. Sometimes, okay, rule of thumb with everything, if the risk of going in and fixing that is less than the risk of it being maintained, then they'll do the surgery. If it's not, they won't do the surgery. Sorry, I got to get some water. Yes.
That's the same as the atrial septal defect, right? Or is it one of the possible atrial?
There are other atrial septal defects, but yes, that is an example. Got to have the coffee too. All right, so mechanical got close to that. Now this guy, where is it? The ductus arteriosus. Remember, that was blood was going from the pulmonary trunk to the aorta. All right, partially because there's that high pressure in the pulmonary trunk pushing to the aorta. So when lungs inflate and you start getting more oxygen in your circulatory system, that high oxygen tension, and by tension I mean concentration, forces molecular changes in that ductus arteriosus to force it, the smooth muscle in there clamps it shut, and it becomes fibrous tissue. Okay, so it's a high oxygen pressure that triggers smooth muscle to contract that and close it up. Ah, crap. I do this. So you guys will notice my slides are usually pretty detailed. The reason I do that is my brain is complete chaos most of the time. So I have to have something to keep me grounded. Then I get ahead of myself and forget that I made all these details and then talk about it, and then it's all on all these slides. And I'm like, oh, we did that, skip it. We did that, skip it. We did that, skip it. So We did all this. Umbilical vessels, we talked about that. Ductus, that's the only thing I didn't talk about, the ductus venosus from the liver. That constricts as well because it's coming from the umbilical veins. Simply lack of blood supply is why that gets constricted, and it closes in about 1 to 3 hours. So when we're thinking about changes from from fetus to after birth, some of these changes are very quick. So functionally, it closes in 1 to 3 hours. That means no blood's going through. Structurally, it closes in 2 to 18 days. So 2 days to about 2.5 weeks. It becomes scar tissue.
So if the ductus venous doesn't close, will just result in them having congenital heart disease and they'll still live? Like if it doesn't constrict properly, will the fetus still survive long term just with having like hypoxemia or something like that?
Yeah, because it's not relying on the mother's circulation anymore. Okay, foraminal valley, we talked about that already. To give you a timeline, it closes from about 6 months to a year. So when your baby's still a year old, they may still have a patent foraminal valley, and that is completely normal. Okay, and we talked about why that is. Dang. I like pictures. Pictures, this is how I think, so the words here help guide me, but if I can do it without it, I just did. All right, ductus arteriosus, this one up here, we talked about that with the high oxygen tension. That functionally closes in hours. So contracting that smooth muscle, that's relatively quick, right? But converting that into scar tissue to become a ligament, it's made up of collagen, about a week. Anywhere within the first week. Okay? Okay, got any questions? All right, now, sometimes, as Jesse suggested, things go wrong. Okay? That's when we end up with congenital heart defects. Now, I'm just going to give a couple examples. There are more than I care to talk about. One of them is a patent ductus arteriosus. So that would be this shunt between the pulmonary trunk and the aorta remaining open. All right? Since it's remaining open and the pressure is higher in the left side of the heart than the right side of the heart now, it's going to be a left to right shunt. What was it in fetal circulation? Right to left. All right? And it's all because of pressure differentials. All right, so if it does that, what we're going to have is a diminished cardiac and respiratory reserve. In other words, if we're sitting here taking notes, if we're walking around doing normal life, we're fine. But as soon as we have to run or some exercise or some stress comes up, we're in trouble because we don't have the reserve to accommodate that increase in activity. So that's the main consequence. All right, how do you know if you have one? It'll come up as a murmur. All right? Can I diagnose this murmur? No. I'm not a cardiologist, and I haven't heard enough of them to know. You guys will be more proficient in murmurs by the time you're done next semester than I am. So this is rare in adults. A more worser one is tetralogy of Fallot. You guys ever heard of this one before? So this is a congenital defect. We talked about all those holes that are in the heart that form in order to accommodate specifically a fetus circulation. When those are forming, something goes wrong with the development, and you end up with tetralogy, 4 occurrences. And these will always occur, but in different severities of each one. So not every tetralogy of Fallot will be the same thing. So what happens is you have an overriding aorta that opens into the right ventricle. So your aorta comes up, goes around the right ventricle, and opens back into it. So almost like a fistula between the aorta and the right ventricle. So now you're getting left blood going back into right blood. You have pulmonary artery stenosis, so that pulmonary artery will be constricted and very rigid. You have a ventral septal defect. So what that means is you have a hole between your ventricles. So you might as well not even have a left side of the heart and a right side of the heart, right? All blood is mixing. And you're going to have an enlarged RV. You're going to have a big thing to go camping with. An enlarged right ventricle, because now, why does the left side of your heart have a much thicker wall than the right side of your heart as adults? Right, you're pumping against a high pressure out to systemic circulation. Okay? If you have a hole in your heart and both chambers have to pump to the lungs and the body, they're both going to have to work really hard. So the left or right ventricle is going to become enlarged as well. All right? Not good. Not good. Babies have a very hard time with this, and I didn't do the reading to figure out how they fix this, so I can't answer that question. But this is one possible thing that could happen, of course, when the circulatory system of the fetus goes wrong, okay? All right. When a fetus is developing, embryo and fetus, the heart and the upper limbs originate in the neck. And if they're originating in the neck, they're going to share neurons from the same spinal cord segment. And for that reason, pain that you feel in your heart will be referred down to your left arm. Okay, because they share the same spinal cord segment. So you may be having heart pain, but your brain's going to interpret that as left arm pain as well, because they share some of the same connections. All right, so that's why one of the symptoms of a heart attack is what? Radiating left arm pain.
Is it same for the opposite? Like if you have like radiculopathy or something, and can it also cause chest pain? Like nerves that go down the arm or something like that?
That's a good question.
One's like pinched.
I will look that up. I don't know. I don't know the answer to that question. If I had to guess, yes, but I don't know. Same thing, because they originate in the neck, and some of those may go radiate up there too. So everybody's going to be a little bit different. Not everybody's going to experience the exact same symptoms of a heart attack, right? Here's another thing. Women don't often experience this. So did something go up wrong developmentally with them? No, it didn't. I know better. I'm married. No. The reason for that is not fully understood. The reason why women have different effects of a heart attack as men do, despite the same setup, is not fully understood. So we don't have... Science doesn't have an answer to that question. All right? Now, when I built my lectures, I try to build up a case and then make an argument. Okay? So the next 10 slides is building up a case to talk about the flow of blood in the heart. To make that case, I tell you what the 4 chambers of the heart are and where the right and left ventricles are. I should probably take that out because you guys just had that yesterday. I know you've had it before sometime in your education. I'm not going to cover that. Is that okay with you guys? Okay. Because when we just went through the blood flow of the heart, you guys knew all the chambers anyway. So I'm going to avoid going through that. What I do want you to know is, as I'm standing here, this is my what?
Right.
This is my,
Left.
okay? So anytime you're looking at a heart, it's the exact opposite, right? Anatomical position. All right, I did want to cover this really briefly, although I think I did it in the anatomy lectures too, didn't I? So the different layers of the heart wall, your epicardium, your myocardium, and your endocardium. And the only thing I want to say about your endocardium is that it is like a real, and you saw this in the anatomage table, real shiny, really smooth surface. And the reason for that, do you guys remember?
Less friction.
Pardon? Laminar flow, less friction, right? Because if you don't have that kind of flow, you have a high propensity for blood clots, and that's obviously not going to be good. That's where your heart attacks and your strokes and all those fun things come in, DVTs. Okay, so I'm going to skip that. I'm going to skip that. I'm going to skip that. Look at how much time I'm saving you guys. I'll do what I do with my kids. What can I say except you're welcome? We did the coronary blood vessels. I have this video out on Canvas for you guys. It basically just shows a coronary angiography. So if you remember from the coronary blood vessels, the openings to those coronary vessels are just on the other side of the aortic valve, right? There's one for the left coronary artery, and there's one for the right coronary artery. So when the ventricle pumps blood out and then relaxes, blood flows back, fills up these cusps, and that's what closes them, right? And if you notice, these cusps are indents, so they're like cups, if you will. And these cups fill, blood flows into the openings or the sinuses of these coronary arteries, and that's when the heart fills. So the coronary vessels fill when the heart relaxes, right? Which is just the opposite of when everything else fills. And so those, oh no, don't do that. It doesn't work on the TV, does it? No? All right. The videos just show you some coronary angiography where they introduce a contrast dye into these vessels and they light up radiographically. Okay? Major vessels of the heart. We talked about those. Now we'll get into the physiology of everything. Okay? Cardiac muscle. All right? The myocardium. This is what it looks like. What does it remind you of? Come on, say it. Skeletal muscle, thank you. Guys. What are some key differences? Right? The intercalated discs. And if you remember, those are gap junctions between the cells that allow ions, specifically calcium, to pass between so the heart contracts as a single unit rather than individual cells separately. Okay? What's another difference? Okay, one nucleus per cell. So that would all be one cell. There's the one nucleus to it. And one more difference. It's involuntary. Looking at the picture.
Branching.
It's branched. Right. You have the branching of the fibers. Okay? Otherwise, it looks just like skeletal muscle. And mostly functions the same, too. In fact, if you guys, I hate this, too. When you talk about muscle contractions and actin myosin coming together, same thing happens. The exact same thing happens here. Aside from protecting coronary vessels, why does the heart have so much fat on it? You guys know why? metabolizes fat. What have you learned in most of your science education that your body uses for energy? Glucose, carbohydrates. Heart primarily uses fats. Okay, so I'm not going to test you on that. That's just something interesting that you should know. All right, so what we're going to talk about are these cardiac action potentials. So how do we get a heart to beat, and how do we regulate it? All right, so this graph shows you ventricular muscle action potential. So this is the electrical event that happens in the muscle itself. All right, one thing that across the board, undergrad, graduate students have always had difficulty understanding to varying degrees is that first, you have to have an electrical event in the heart. Then you can have your mechanical event. Okay? A good analogy is, in order for the blades of that fan to turn, I have to plug it in first, right? So you have to get electricity to the heart before it can actually contract. So this is what ventricular muscle action potentials look like, and we'll talk about the nervous system action potentials in a few minutes. So you guys should be able to identify these different parts and understand why they work the way they do. So all of these are the same, all right? So even though I may be talking about this one, I will reference 1, 2, 3. It's the same thing going on here, okay? So I'm not talking about two different things, okay? So here's resting, all right? At some point, fast sodium channels open. Now, when sodium channels open, let's assume it's a terrible muscle fiber. All right, let's assume that's a muscle fiber, cardiac muscle fiber. All right, it's resting. When I open up a sodium channel, what happens? Okay, how? Where does sodium go? Notice I didn't draw sodium. Sodium goes in, okay? So that will depolarize, making the inside of the cell more positive, okay? So down here you see time. Up here you see membrane potential. So resting about minus 80, here we get less negative or more positive. Okay, so sodium goes in immediately. So fast sodium channels. What does that mean? They open up really fast and a lot of sodium goes in. All right, so that's going to depolarize almost instantaneously. All right, about 80% of the way up, slow calcium channels open. All right, so that's going to help further depolarize it more than just the amount of sodium going in. Because will sodium stop at some point?
Yeah.
Why?
Equilibrium.
Equilibrium, good. So you open up these slow calcium channels to bring it up to an even higher potential until potassium channels open. What's potassium going to do? Potassium will repolarize by going out, right? So potassium will go out. You're having positive charges move out, all right? So that's going to start taking it down to a more negative level. But then about halfway into that, more calcium channels open, all right? But what do we know about calcium channels? They're slower, okay? So because they're slower, you're going to have more of a plateau effect rather than going back up, okay? So that's going to slow down the repolarization. Now, the purpose of this is so that our heart beat at a certain pace rhythmically. Okay? This will keep things depolarized. If a cell, neuron, muscle, whatever, is depolarized, can you depolarize it again at that point in time? No. That's called refractory period. Okay, so this helps prevent immediate depolarization again. All right? So then more potassium channels open, enough so that like a shit ton comes out, and that is a scientific term. Specifically a metric shit ton. Potassium comes out, and you go back to resting. All right. Not important to what you guys need to know for this, but let's just see how much you remember. As it gets back down to resting, during this period of time, what's happening? What's a really important thing that's happening during that resting potential? Something everybody forgets. Do what? Okay. Give you a hint. It's a pump. Sodium potassium pump. So you have a bunch of sodium potassium pumps here that are pumping sodium back out and potassium back in, so you restore that gradient. Okay? So that's really important. It's not important enough that sodium's going in and potassium's going out. You have to restore that gradient somehow, and that's what's happening during that the resting potential. So notice that from the start of an action potential to the end of an action potential is a fraction of a second. So it's less than half a second. Let's say 0.35 seconds. That's
What is the sodium potassium pump restoring during resting period?
sodium and potassium gradients. So if you want sodium to be in high concentration outside to come in, you have to pump it out of the cell once it goes in.
Yeah, when does that happen? The refractory period?
Actually, it's happening during the whole thing, but mostly during here to restore those gradients. So let's make an argument. You're pumping sodium back out at a slow rate, and all of a sudden, and you're, what is it, 3 out? 3 out, 2 in, 2 potassium in. So 3 out, 2 in, 3 out, 2 in. And then all of a sudden you let 10,000 sodiums in. Even if that's occurring during here, is it going to be able to keep up? No. So that's why I say consider it going on here. Even though it's still going on here, it's never going to do anything meaningful. All right. That was fun. Does that make sense for the most part? Okay. So that's what's happening in the heart itself, in the heart muscle. All right. How do we get the heart? So, in other words, in order for sodium channels to open, you have to depolarize that muscle cell. All right? In order to depolarize that muscle cell, you need some sort of stimulation going to that muscle cell to depolarize it. And that's where the cardiac conduction system comes in. All right? These are the electrical events. This is plugging in the fan before it starts turning on. Okay? So, they all start at the sinoatrial node, or SA node, which is right here between the superior vena cava and the right ventricle, or right atrium. All right? It's also known as the pacemaker of the heart because it spontaneously sends action potentials. All right? Spontaneously sends action potentials at irregular intervals. Okay? As this is sending action potentials, it's going, you have a bunch of fibers that are connected to both the right and left atria. So those signals are going to be sent to them. That's going to cause the right and left atria to do what? Contract at some point. Okay, so left and right atria. But then you also have a direct line going down to the next structure, which is between the right atrium and right ventricle, known as the AV node, all right, and we'll get there. the spontaneous rate of the SA node. So let's say we remove the sympathetic nervous system and the parasympathetic nervous system from the heart, and the heart is its own entity, not hooked up to the nervous system. Your heart rate would be about 70 to 80 beats per minute. But what's normal heart rate range? 60 to 100. So if this is 70 to 80, how do we get down to 60? Parasympathetic is always putting brakes on, okay, to regulate your heart. All right, but without it, that's what your heart rate would be. Still within normal range, but not able to be regulated. All right, how does this spontaneous firing work? All right, based on what we saw in the muscle cell, what did resting potential look like? It was flat, right? What do you notice about resting potential with the SA node? It has a positive slope, all right? So that means resting potential is always getting more negative on its own. Why is it getting more negative? Because you have leaky sodium channels in the SA node. If you have leaky sodium channels, then sodium ions are slowly trickling in over time.
Negative or positive?
Did I say negative?
Yeah.
More positive, yes, more positive. Thank you. Yes, going this way, more positive. So, because sodium's leaking in, it's trickling in. We call them sodium leak channels. Okay? Once the potential of the cell reaches threshold, right, and threshold is where all of the voltage-gated sodium channels open up, then you have depolarization, rapid depolarization. That's an action potential. Okay? But notice what's opening up. Is it sodium channels? It's calcium channels. So when we see voltage-gated sodium channels open up, the action potential typically looks like this, straight up, right? But you notice that when the potassium or slow calcium channels open up, it's slower. Okay? So it takes a little bit more time. Right? So slow calcium channels open, potassium channels open up, and then you get the repolarization. Okay, taking it back down. Leaky sodium channels, back to threshold, depolarization with calcium, open up potassium channels, back down. Okay, happens over and over and over again. So it's that leaky sodium that's responsible for the continuous back up to threshold. Back up to threshold. What's an example I can give of that? It's like, you guys ever go to like Great Wolf Lodge or any of these water parks where they have that giant ass bucket that keeps filling with water? So it's got that leaky water, then all of a sudden, whoop, and then it fills up again. So it's like a leaky sodium channel. And then at regular intervals, it'll go boop, fill up, boop. So imagine leaky sodium channels filling up the SA node cells, and then the bucket tips over, then goes back. Okay?
The voltage-gated channels at once threshold is reached is the what ion?
Oops. Calcium. Did I say sodium before?
Yeah.
I'm sorry.
That's what I want to make sure.
Yep. Thanks. You guys call me out. I appreciate it. All right, so here we have superimposed this ventricular muscle fiber action potential. And what do you notice that happens? You have your action potential of your pacemaker cell. Then you have your action potential of your muscle fiber, right? So electrical signal from the heart's nervous system to an electrical signal in the muscle cell, then the contractile event can happen. Good? All right. All right, so we go down to the AV node. All right, that spreads to the atria. They're going to depolarize. We go to the AV node. The AV node is responsible for conducting the electrical impulse down into the ventricles. All right, what it does specifically is it delays the conduction. So from the SA node to the atria, really quickly. From the SA node through the AV node happens slower. Why would you want to slow down the impulse going to the ventricles? So blood can fill? Okay. Why else?
So the entire heart doesn't just contract all at the same time without any.
Good. You want a specific sequence of events. So the atria have to contract first, and then the ventricles have to contract. So very rapid contraction, slow it down so that these can contract afterwards. All right. If we were to strip away the SA node connections to the AV node, our heart rate would be about 40 to 60 per minute. So that tells you that the AV node is also capable of doing what? Spontaneous action potentials. All right. Then we go down to AV bundle, which divides into the left and right. Did that backwards, right and left? Yeah, left and right, bundle branches, right? The AV bundle. Also known as the bundle of His. All right, so this guy, Dr. His, decided to name this after himself. If you hear it, they mean the same thing. I will always use AV bundle. So that can also send action potentials about 30 to 40 per minute. The bundle branches left and right, about 20 to 30 per minute. If these come into effect when you have like blockages, bundle branch, like conduction blockages in the heart. That's why these become important. And then these divide into Purkinje fibers. So once it gets down to the apex of the heart, these fibers go up into the cardiac muscle, these Purkinje fibers. They're the last to contract. They start here at the apex and then work their way back up. All right? They can go at about 15 to 20 per minute. All right? So not only did you slow down the action potentials going down to the apex of the heart, but you started the contractions at the apex and then electrically signaled them going back up towards the base. So what does that mean? That means the apex of the heart is going to contract first, followed by the base. So literally you're squeezing blood out as it pumps. All right, now I don't have the slide in here, but the muscle fibers of your heart, some people have done really neat dissections where they delicately take apart the muscle of the heart, and they found out that heart muscle wraps kind of around. So not only are you stimulating the apex of the heart to contract first, but as it's contracting, it's ringing, kind of like those mops, so that you can get more blood out with each beat, okay, as opposed to just strictly contracting. All right, so that leads us to this. Next semester, when you guys get to the physical exam lab, one of the first things we'll be doing, and this somehow gets put on me, and I don't mind it, I'm not saying that. I will help you learn how to hook up 12-lead EKGs, okay? Because that's one of the things you need to do. And you're not doing it for physical exam class. You're actually doing it for your EKG class, all right? Just so you have that experience of learning how to do it. And make sure you know that well, because you will be tested on it next year at this time for your clinical readiness exams, okay? FYI, put that back here. Has anybody done 12 leads before? Okay, so I will call on all of you. Actually, I'll probably put you guys into groups where one, and then have you lead it, and I'll help direct. So we'll worry about that when we get there.
You are a
I was pissed. You are a chosen people. Don't forget that. It's interesting. I'm not making fun of prayers, really. It's interesting what people decide they say. I just find that fascinating. All right, EKGs or ECGs, electrocardiograms. This is what your basic EKG will look like. We're not going to learn how to read it. I don't care that you know how to count boxes. Okay, you'll learn that in your EKG class. That's not what this is for. I need you to understand what the waves are and what they represent. Okay? So, this would represent one cycle of the heart. Okay? You have the P wave, the QRS complex, and the T wave. All right? The P wave represents atrial depolarization. Okay, notice millivolts is going in a positive direction, so depolarization. Actually, forget I said that. Because then, for something else, you guys are going to be like, I thought you just said. All right, so atrial depolarization. All right, then we have a small break, then we have a downward deflection, up to the R, back down to S, and then the baseline. That is known as your QRS complex. Okay? This is your ventricles depolarizing. And since the ventricles are so large and have a lot of muscle tissue and nervous tissue in there, you're going to get a more complex waveform. Okay? So, QRS complex, that's ventricular depolarization. Okay? And the reason why it's so much bigger than atria, again, more muscle. Okay? And then you have a little bit of break, and then you have ventricular repolarization. Ventricular repolarization. This is where you're like, if repolarization, that's going back down, but why is it going up? You'll learn that in your EKG class too. Okay? Ventricular repolarization. What's missing? Atrial repolarization. Where would that occur? Right here. Why don't we see it? Because the ventricles are so large it masks that. So we'll never see atrial repolarization. Okay? So we're going to get to the cardiac cycle, and it's 9:02. I'll give you guys a break. But P wave, ventricular depolarization, your contraction of the atria, or atrial depolarization. Your contraction would happen here. QRS, ventricular depolarization. Your contraction would happen here. Okay? Electrical event, mechanical event. Electrical event, mechanical event. Okay? This is just getting to the electrical, so you're not going to see the mechanical here. All right? So when you guys start analyzing these, what you're going to be doing is measuring how many boxes or how much time is between, like, the P wave takes to take place, the QRS takes to take place, between the T wave and the QRS complex. So between the R waves to get a heart rate. So those kind of things you'll be figuring out. Not important for this class. Okay? So why don't we take a 5-minute break, and then we will come back and finish this up. Let's continue. All right, so you guys are experts in EKGs, right? Yeah, you guys are experts in EKGs now, right? Yeah. Sweet. All right. I know that's not true. Yeah. That didn't work. All right. Actually, I do have a picture. These are the muscle fibers going around kind of a diagonal. Remember I said the twisting thing? I forgot I did have a picture of that. All right. So here's how this works in reality. Okay, remember your SA node is right around in here. You're going to fire into the atria first. All right, so you see this yellow represents the atrial depolarization, and you see the wave forming on the electrocardiogram. All right, then once they're fully depolarized, there's your P wave. All right, that got delayed. You go down here, you start to see the ventricles depolarizing. Once they're fully depolarized, you have the QRS complex. All right, then you see the ventricles start to repolarize. Start of a T wave, fully repolarized. There's your T wave. Okay, so that's showing what's happening in the heart and how it creates the electrocardiogram. Okay, if you guys needed pictures to go along with the EKG. That's all that's saying. I'm not coordinated enough. All right, how do we regulate the cardiac cycle? Electrically. All right, we know that the SA node fires spontaneously and it can control heart rate. What are some, but we change our heart rate all the time. And they're actually finding out now, more research, especially with people in the functions on the watches, heart rate variability is really important. The more variable your heart rate is throughout the day, the healthier you are. Okay? This is the kind of stuff that like is breaking, but like won't reach boards until like 20 years from now. Including, never mind. So what are some conditions where you might want to change your heart rate?
Having like bradycardia and your heart is not pumping fast enough, so you need to increase your heart rate in order to go back to your normal.
Okay. What else? Exercise. What else?
Sleep.
Good. Sleep. I was hoping somebody mentioned that. What else? Being chased by a monster. Fight or flight? What kind of monsters? I tell my kids my son is scared of monsters. He's scared of the dark, so every time we have a split level house, and every time he goes downstairs, which is not a basement, it's still light down there or whatever, and he runs upstairs, I'm like, those monsters get you? Shut up, Dad. He's going to be 12 next week, and now it's getting to the point where he just rolls his eyes and basically says fuck you under his breath. So yeah, those are all reasons why we might want to change our heart rate. What should happen to your heart rate when you sleep? So as I'm doing this, slows down. All right. Our parasympathetic nervous system is attached to our heart through the vagus nerve. All right, you guys found the vagus nerve in the anatomage table. Vagal stimulation is constant. And what that means is that you have this vagal nerve coming down, and it's regularly firing action potentials. Actually, on a graph, that would look like, right, action potentials just firing at a regular interval. Okay, slowing it down. And it does so, remember the vagus nerve, our parasympathetic releases ACH. You guys know what that is? Acetylcholine, good. And acetylcholine opens up potassium channels. So if you open up potassium channels, what are you really doing to a cell? You're making it more positive or negative? More negative. You're hyperpolarizing it, all right? So if you open up, I need to put this down. If you open up your potassium channels and hyperpolarize, you take in your beginning of your resting potential and moving it down a little more. If you move it down a little more, it takes a little bit longer to get up to threshold. And then you have the same action potential. So this is the mechanism by which you're slowing your heart rate down. You're making that potential more negative, so it just takes longer to spontaneously fire. Does that make sense? All right. Sympathetic nervous system will increase heart rate. So you have sympathetic fibers going to the through accelerator nerves. You didn't have to find that. They will increase heart rate through the actions of norepinephrine, right? Because that's the neurotransmitter at the end of a sympathetic pathway. They will open up sodium and calcium channels, all right? When you open up sodium and calcium channels, more of them, you're going to put your resting closer to threshold. So if it's closer to threshold, it doesn't take as much time to get there. Therefore, you're going to fire spontaneously much quicker. Okay? So parasympathetic gets you farther from threshold. Sympathetic gets you closer to threshold, and that's a mechanism by which things are made faster and slower and faster, respectively. All right? Now, parasympathetic will only go to the SA and AV nodes. All right? So parasympathetic can only regulate heart rate. Sympathetic can go to the SA and AV nodes, but it can also go to the myocardium. Pretend that says myocardium. So that will increase your strength of contraction. Right? If you increase your strength of contraction, that will allow you to pump more blood per beat, which is known as your stroke volume. So it increases your stroke volume as well. All right? So sympathetic only controls heart rate. I'm sorry, parasympathetic only controls heart rate. Sympathetic controls both heart rate and stroke volume. I will ask a question about that. All right. Where are the regulators for this? Medulla oblongata. All right. You guys should know by now that your brainstem, which includes medulla oblongata, is where all your life functions happen, right? That's where all of your base set points and everything are. So in the medulla oblongata, you have your cardioinhibitory reflex center. So that would activate which branch of the nervous system? Parasympathetic. And your cardioacceleratory reflex center, which would activate your sympathetic. Okay? And then throughout your body, you have these baroreceptors, which respond to changes in blood pressure. Okay? And these, if you remember when we talked about in the respiratory system where the oxygen sensors are, right here, carotid bodies, and the aortic body, that's where your baroreceptors are located as well. And those are going to be your sensory input to the spinal cord going up to your brain to say, hey, I need to raise or I need to lower my heart rate. So let's do a thought exercise real quick. If your blood pressure is high, actually, let's do this. Cardiac output, actually, let's do this. We'll go back to that. Blood pressure is a function of cardiac output, how much blood's being pumped from the heart, times peripheral resistance. In other words, what kind of force does the heart have to pump against? Cardiac output is a function of heart rate and stroke volume. Okay? So, if I increase heart rate, what do I do to cardiac output? It increases. If I increase cardiac output, what do I do to blood pressure? Increase. Okay. Knowing that, if I have an increase in blood pressure for whatever reason, what do I want my heart to do? Slow down. I'd want my heart to slow down. Okay? And so if these baroreceptors detect an increase in blood pressure, they're going to send signals through the spinal cord up to the brainstem and say, hey, blood pressure's high, slow down that heart rate. Heart rate will slow down. Okay? If my blood pressure gets too low, same thing. It'll send those sensory signals to the spinal cord up to the medulla, say, hey, blood pressure's a little low. You might want to kick in the cardioacceleratory reflex center and raise that heart rate up, which will also raise stroke volume up. Therefore, increase blood pressure, right? Okay, good. All right. We're not going to do this again. Is that okay with you guys? All right. So some people like flow diagrams. Some people like pictures. Both are here. I don't give a shit which one you use. Know the path of blood through the heart. Okay. We already did it once. We did it with the what did we do it with? Fetus. And if you guys are interested, there was a commercial years ago, St. John's aspirin, and they did a little ditty about blood flow through the heart and why you should take aspirin every day to prevent blood clots. So it's on Canvas. Listen to it. It's fun. All right. Now we'll get into the cardiac cycle. We talked about the electrical events. Here are the mechanical events. All right. I remember when I was, not near seats, but undergrad, and I saw this, I was like, what the fuck? All right. Cardiac cycle. All right. There's a clue. Actually, we don't have time for that. Whenever we talk about blood pressure, or we talk about heart rate, or we talk about any of these things, which side of the heart are we usually talking about? The left side, because that's the one we can measure. All right. If we want to measure pulmonary stuff, we have to get all invasive and gross. So everything is usually about the left side. So all of these apply to both the left and the right side, but we talk about the left side because that's what we can measure. Okay. So that's why you'll see the aortic valve, and you won't see the pulmonic valve, but the pulmonic valve is doing the same thing. Okay. So get that out of the way right away. What we see here, here's your EKG. So that's your electrical event. Here are pressures in the left ventricle. That's your mechanical event. These are what happened to blood volume during that mechanical event. And this is what heart sounds are down there. So what this diagram gives you is a full cardiac cycle and how electrical and mechanical events are related to each other temporally, meaning in time. So you notice here's the peak of your QRS complex, and notice that your mechanical event starts just after that. Okay? So that's one of the really important things to take away from this. All right, so you guys can go back to that picture. I just found out that you guys like to draw in that picture while I'm going through these, so that's fine. So these all refer back to that original picture. So we have systole and diastole. What is systole? Contraction. What's diastole? Relaxation. All right. Can I have left ventricular systole without right ventricular systole? No. No. Maybe, but it's abnormal. That would be bad. All right. So, again, what's happening in the left side of the heart, which is what we're describing, is also happening in the left side of the heart, right side of the heart. Okay? So contracting and relaxing. That's what systole and diastole mean. All right? Then we have our EKG. Right here, we talked about that. Let's move on. All right. This little dotted line right here is what you guys talked about with Professor Gavin yesterday when you measured that jugular venous pressure. Okay? This is the atrial pressure wave. Okay? So atrial pressure, when's the pressure in the atria going to be the highest? Actually, what two things can affect atrial pressure? Two things. Fills up with blood, and it contracts, right? Both of those. When it fills up, pressure builds. When it contracts, pressure builds. All right? So, here would be When this says systole and diastole, what it's referring to is ventricular systole and diastole. So notice that this A wave, which represents atrial contraction, is happening during diastole because it's diastole of the ventricle. Okay? And then the C wave. Okay, so A wave, that's atrial contraction. That's a pulse, right internal jugular vein. You guys saw that when you measured the central venous pressure, the JVP, yesterday. Yeah, was it yesterday? Yeah, it was yesterday. Did you guys do it Tuesday too? He tends to repeat himself. Okay, the C wave, then notice that that's occurring during ventricular systole. That's a ventricular contraction. The AV valves are so the papillary muscles pulling on those cusps. Ventricles contract, but they push those cusps up into the atria too, like they're pushing against a force. So those are going to bulge. That's going to increase atrial pressure as well. That's something we don't think about. So that's what creates this C wave. So notice it's occurring during ventricular contraction. And then the V wave, that's the flow of blood back into the atria. And notice that the pressure of the flow of blood back into the atria is much less than when the atria are actually contracting. Okay, so those kind of relationships, when things are happening in relation to other events, are the important things to get out of these slides. All right, systole, ventricular systole, specifically left ventricular systole. All right, we're going to describe that in terms of these pressure waves. All right, so at the beginning of systole, right after you have maximum QRS complex activation, the pressure in the ventricles starts to increase. But both the AV valve, which is what? If it's in the left ventricle, what's your AV valve called? The mitral valve. Good. So the AV valve is closed, but your aortic valve is also closed. All right, so you have this period of isovolumic contraction. That means no volume change. Both valves are closed, blood's not going anywhere, so you're just increasing pressure. Huge pressure increase. Once the pressure of the ventricle overcomes the pressure in the aorta, that valve opens, and now blood can come out. So pressure goes a little bit higher, blood is forced out. And that's why you see volume coming down here. Does that make sense? Okay, right after isovolumic contraction. Right? So this phase right here, this hump, is the ejection phase. All right? Then once you've fully contracted and you can't contract anymore, that pressure is going to go down, the aortic valve is going to close, then you're going to have isovolumic relaxation. No change in blood volume, but the pressure is going to continue going down until it goes back to baseline. Okay, and the AV valve opens to fill again. I just got ahead of myself again. So we just talked about this in the last slide, but the only other thing I want to mention is that when the ventricles are relaxing and the atria are filling up, there's going to be a leak from the atria to the ventricles. All right? In fact, 75% of your blood volume that goes into the ventricles from the atria comes from passive filling. So why do the atria contract at all? To get the rest in there. Okay. The only thing we didn't mention about this, okay, and then it was during diastole, it's filling back up. The only thing we didn't mention in this are the heart sounds. All right? And I brought my stethoscope today and forgot to bring it to class again. So, heart sounds. You have 4 of them, actually. The first heart sound is S1. All right? It's the loudest, it's a low-pitched sound, and it's made from the AV valves closing. You looked at the heart yesterday. What's bigger, AV valves or semilunar valves? What's bigger, mitral and tricuspid or aortic and pulmonic? The mitral valves, right? So when they close, they're going to make a louder sound. All right, so that's your first heart sound. Where might this be heard the best or the loudest? What's this? What's this? Sternal angle. What's this? Second intercostal space, right sternal border. What heart sound do we hear here? Aortic. Go right across. Second intercostal space, left side, sternal border. Pulmonic. Herbs. Tricuspid. Mitral. Okay. So where might these AV valves best be heard? Tricuspid, mitral. Right. That's where you hear them the loudest. Second heart sound, S2. Those are the semilunar valves closing. Where might those be heard? Second intercostal space, left and right sternal borders, right? Where those are. Now it's interesting, and I recommend doing this. Go home, get your, or like between classes, get your stethoscopes out and listen. Listen here. You hear. If you're listening to the pulmonic area, you'll hear the second sound much louder. Once you move down here, you'll hear the first sound much louder. Okay? And let's say you suspect a murmur in the mitral valve. Right? You're not going to want to listen here for it. You're going to want to listen down where that mitral valve is located. Okay. There is a slight time difference between when an aortic valve closes and when a pulmonic valve closes. So if you listen really carefully and you get good at listening, you can actually hear the 2 separate sounds in S2. That's called an S2 split. Just want to make sure I'm recording. All right. So, third heart sound, made from blood rushing into the ventricles. You more than likely will never hear that unless it's an abnormal condition. Okay, so we consider it a third heart sound, and if it is heard, it can be normal, but more often than not, it's not heard, and if it is abnormal. Okay, so third heart sound, S3. And then the fourth heart sound, S4, is also very hard to hear. I can't pick it up. I'm very bad at this, though. Ask my wife, I don't listen. And also generally abnormal. All right? So we're really concerned about the first 2 heart sounds. So if we go back, let's go back to the big picture. Here's our electrical event. Here's the first heart sound. AV valves closing. Right, this is at the end of the previous cycle. AV valves closing, that's our first heart sound. Ventricles are contracting, AV valve opens, AV valve closes, second heart sound. Okay, and then we go again, AV valve, semilunar valves, sorry, AV valves. Okay, so that's where they lie in relation to what's going on with the cardiac cycle. I guess I had it right here too. All right. Going back to this, these volume changes that we talked about with the pressure changes, when our heart empties, our ventricles empty, the amount of blood that's left in the ventricle, so you don't pump all of it out. Okay, so know that you will never pump all the blood out of your heart. That's called the end systolic volume, end of contraction volume that's left. When the heart fills, that's the end diastolic volume. So when it's completely relaxed, the maximum amount of blood that can fit in there. The end diastolic volume minus the end systolic volume equals how much blood you pumped out, which is your stroke volume. So that's what this is trying to get at. So let's say our end diastolic volume is 120 milliliters. All right, so the heart fills up with 120 milliliters of blood. We measure it again after systole, and we get 50 milliliters left over in there. So that minus that equals 70 milliliters. That means 70 milliliters were pumped out with the previous contraction. That's called our ejection or stroke volume. Okay? Normal, yes. All right? Now, the concept associated with that is called ejection fraction. And this is a more diagnostic term than stroke volume is. Ejection fraction is stroke volume divided by end diastolic volume. So how much blood did you pump out in relation to how much blood was already there? And so if we take these numbers, 70 divided by 120 equals 58%. Normal stroke volume, normal ejection fraction is about 60%. So is that normal? Yeah, relatively normal. Okay, let me ask you something. In physiology and medicine, is there ever one number that describes everything? No, it's always a range. So normal is around 60%.
Are you more concerned if it's higher or lower than the normal range? Or is it more like a margin issue?
Well, if you have a 20% ejection fraction, are you getting blood out to your brain or your body tissues? No. So it would be the lower number. That would be more of a problem. What would a higher number mean? Too much high blood pressure. Right. All right. We already talked about this. Cardiac output is heart rate times stroke volume. If our heart rate is 70 beats per minute, 70 per minute times 70 milliliters equals 4,900 milliliters per minute. That is cardiac output. Normal is about 5 to 6 liters per minute. So 4,900 is pretty close to normal. Okay? So these are how you calculate some of these different things. And that will help us with our discussion. What was that? That was fun. I didn't do that. I don't put those in my PowerPoint presentations because they're obnoxious and they take time. You guys created PowerPoints, right? It takes forever to do those kind of things. That's why I leave them out. Anyway, all right. Aortic pressure curve. So this is going back to the previous discussion that we had with this picture. This dotted line right here, remember this was pressure in the right atrium. This is the pressure in the aorta, all right? So what you're pumping out from the left ventricle. Notice aortic pressure starts increasing during systole. So here's aortic pressure increasing during systole. And then the pressure of the ventricle goes above the pressure of the aorta. Blood flows out. And then the pressure of the aorta, blood flows, when the ventricles start relaxing, blood flows backwards. Pressure of the aorta reaches its maximum. Above that of the ventricle, valve closes, okay? And then comes back down. And then when it closes, it makes this little thing called an incisura, okay? And that's the backflow of the blood towards the ventricle. All right, important to note here, we're talking about this right here, the aortic pressure decreases slowly when the ventricles are relaxing because of the elasticity of the aorta. Okay, so that elasticity allows for the compensation of some of that pressure. I got to go back in and fix that. All right, why do we have valves? Valves prevent backflow. We've talked about how they work. And I will also say another thing to note is that because of the smaller opening in the semilunar valves, velocity through there is much faster than through the AV valves. So imagine like a dumping of blood as a, actually, take out a hose, turn it on, you have water flowing. That would be like the AV valves. Put your thumb over it, water goes faster, right? Because you made a smaller opening. That's like the semilunar valves. Okay? And I'm like, is it really going to do this the whole time? All right. Most of the work of our heart, of the valves, is external work. All right. Internal work would be the actual contraction of the muscle. External work would be the forces of pressure and volume on the heart. All right. So we can measure or kind of figure out what this work is using pressure volume curves. You guys ever seen these before? They're fun. Sometimes. All right. The amount of work a heart does, the external work, is affected by preload and afterload. And these are really important concepts to know. Preload and afterload. Preload is your volume load. Okay? Where does your volume come from? Blood, right? So it's your volume load. How much the heart's stretching based on the amount of volume that's coming in. Okay? Afterload is a pressure load. So it's how much pressure your ventricles have to pump against. So, in other words, volume is the blood coming into the heart. That's why we call it preload. Pressure is the load that you're pumping against. That's after the heart. That's why we call it afterload. All right. Which one is better for you? An increased preload or an increased afterload? Increased preload. Increased afterloads are what happen during hypertension. Okay? So if you have a higher resistance, let's go back to this. Blood pressure equals cardiac output times peripheral resistance, resistance to blood flow. If I increase resistance, what happens to blood pressure? I increase blood pressure. That's because we increased afterload. Okay. All right, that leads into the Frank-Starling mechanism. And Frank-Starling was, we won't talk about it. What this basically says is that the more blood that comes back to the heart, the more the heart stretches, therefore the harder it's going to contract to push blood out. Okay? The more blood that comes in, the more the heart's going to stretch, the harder the heart has to contract to pump blood out. All right? And that's what we call an increase in contractility. Contractility is one of these really funky terms that people have a hard time understanding. But that's basically what that is, the strength with which the heart's going to contract. All right, so this is what a pressure volume diagram would look like. Really easy to understand once you know what's going on here. So let's start here. End diastolic volume. What just happened to get there? It's fully relaxed, right? End diastolic volume, it's fully relaxed. It filled up. right? All right, so let's say it's fully relaxed, it fills up. We start contracting the ventricles. All right, is volume doing anything? That's your isovolumic contraction. Until the aortic valve opens, then you start getting rid of volume. That's your ejection. Then we reach end systolic volume. All right, so end systolic volume, end diastolic volume, that's our stroke volume, right? Then we relax the ventricles. Notice volume's not going anywhere. So that's isovolumic relaxation. AV valves open. You fill back up. Okay? So that's what's going on here. Everything we talked about with the cardiac cycle is going on with this pressure volume loop. I actually did these in rats. We would anesthetize rats, cut them open, stick a catheter down their aorta, and get these kind of loops. It was really cool, except when I cut the catheter one time before I took it out of the rat, and that cost $10,000. Don't ever do that. All right, are we good with that? Fairly straightforward. All right, let's use that. This is describing the same thing, okay? This is just the same thing, different view. So use whatever, I don't give a shit. All right, if we have an increase in preload, what does that do? These pressure volume loops can show you that. All right, so here's our normal pressure volume loop. If I increase my preload, if I increase the amount of blood going back to the heart, that's going to increase my end diastolic volume. If I increase my end diastolic volume, then that's going to increase the amount of blood I have to pump out. But I'm still going to empty at the same point. And then it relaxes. So if I increase my volume and pump that out, what that effectively does is increases my stroke volume, right? So that's the Frank-Starling mechanism on a graph. Okay, and I wrote this here so you know, larger volumes, no change in pressure. Why don't we have a change in pressure? What accounts for that? The stretch. Good. Excellent. All right. If I have an increased afterload, though, okay, so I go to my end diastolic volume, I contract, but my heart has to pump that much harder to overcome the pressure. So my pressure goes up, okay? And because my heart's already contracting to get that volume out, I can't get as much out because I spent that pressure just trying to open the valve. All right. So that means what happened to my stroke volume? It actually decreased. Okay. So then you go back down, and your stroke volume is actually decreased in spite of the higher pressure. So when I asked you earlier, which do you think is better, preload or afterload? Does that help explain why? Okay, you're not pumping. What the hell am I doing? Pumping more blood out, not pumping more blood out. It's bad. All right, if I have an increase in contractility, first of all, what does that mean? Increased force, increased strength of contraction. All right, and diastolic volume, isovolumic contraction. I'm contracting even stronger, but I don't have a higher pressure to pump against, so it's not going straight up. I can open that valve at the same pressure. I pump more out, come back down, and do it all over again. What did I just do? I increased my stroke volume. All right, so I can increase my stroke volume by increasing the load that's coming in or increasing my contractility. Does that make sense? Okay. we actually talked about a lot of this already, so I'm going to go over it really quickly. Remember, sympathetic stimulation increases heart rate, also increases contractility. We talked about that. It goes to the SA and AV node. It also goes to the muscle fibers. Before we go on further, what's an individual's maximum heart rate? Do you guys know how to figure that out? Say it again. 220 minus your age. All right, so if you're 20 years old, your maximum heart rate should be 200. If you're 50 years old, which I'm approaching very rapidly, your maximum heart rate is 170. If you go out there and run and your heart rate starts getting 180, 190, which happens to me, you have problems, okay? So let's say heart rate's 180 to 200, cardiac output's 15 to 20 liters per minute. Oh, so heart rate can go up to 180 to 200. Cardiac output, 15 to 20 liters. Remember, normal is 5 to 6 liters per minute. You can go up to 15 to 20. So we can improve. Sympathetic stimulation improves the amount of blood we can eject based on our heart rate and stroke volume. Parasympathetic, remember we said it only decreases heart rate. Does it go to the muscles? So does it affect contractility? No. Okay? Only heart rate. All right, really important to remember. We did this when we did about respirations. If we have tachycardia, which means what? Fast heart rate. We're pumping really fast. We don't give our heart time to relax. So does it fill? No. If it doesn't fill, then you're not pumping out as much blood, so you're actually decreasing your cardiac output. All right, so what that tells you is that there's a fine balance. Usually we think, because we made the argument that cardiac output is heart rate and stroke volume. If we increase heart rate, we increase cardiac output up to a point. Okay. Is this the last slide?
No,
One more? Oh, sweet. I am right on time. Look at me. I'm pretty proud. Okay. So this kind of shows you the effect of the sympathetic and parasympathetic on cardiac output as it relates to heart rate. Okay? So, again, if we had a heart that's not connected to our nervous system, do you guys remember what the normal rate for that was? 70 to 80 beats per minute. Okay? Why do we have right atrial pressure down here? What does that signify? Right. Which signifies how much blood is returning to the heart. Okay? So, if you increase your cardiac output, are you going to return more blood to the heart? Yes, that's kind of what this is showing. So, if we have zero sympathetic stimulation, just the SA node firing, our cardiac output is going to be about 10. All right, that makes sense because if we have a higher heart rate, of course we're going to have a higher cardiac output. We know that normal is 5 to 6. So if we include that parasympathetic stimulation and decrease our heart rate down to normal ranges, you're going to have a lower cardiac output, right? Okay. Then let's see, normal sympathetic stimulation. You're in front of a class who doesn't talk, teaching, walking around a lot. Heart rate's going to go up. I may be pumping. Oh, I'm not talking about me. I'm talking about hypothetical things. Cardiac output will go up, right? Because my heart is working harder to maintain my activity level. Strenuous exercise, go up to about 25 liters per minute, okay? So This is the effect of the sympathetic stimulation on cardiac output. Okay? So if normal sympathetic stimulation takes you here, that may be just heart rate. This would be increase in heart rate and contractility. Okay, that's why it's able to go up that much farther. All right, last thing. Is it only those two things? Yes. Okay. Little discussion about ions. We know that potassium and sodium are absolutely essential to maintain potentials, right? For hearts to contract and relax. If we have too much potassium, that will actually decrease contractility. Too much potassium decreases contractility.